Hey YouTubers, today we're going to go through a bit of an orientation to the human body. The whole idea of this talk is to give you a bit of an idea of how medical professionals talk to each other and discuss the human body. We have to describe different positions that we find the human body in, different parts of the body. We have a lot of very specific terms for the different parts of the body that we use with each other. So if you're getting into medicine or allied health in any capacity, you're going to have to know the vocabulary of how we describe the human body and how we communicate with it, about it. So that's what this talk is about. We're going to cover a bunch of things. We're going to talk a bit about the difference between anatomy and physiology, and also pathophysiology and assessment and treatment and all that sort of stuff. We'll talk about the major parts of the body, and this is the bulk of it, taking a head-to-toe approach about the different parts of the body, the different names and nomenclature that we have for the different parts of the body. Talk a little bit about surface anatomy, mostly of the torso, and then we'll talk about the chest topography. The chest is really important, and knowing where things are on the chest, it's important to be able to speak about that with precision. So we'll talk about how we describe the chest and the lines on the chest that describe how far around you are as you go around the chest. Then we'll talk about the positions of the body. So that means in terms of positioning the body itself. So if somebody's lying face down or lying face up or sitting up or lying on their side, what are the medical terms that we use to describe that? We'll talk about slices and sections of the body. Sometimes we'll be looking into the body in a certain way when we're looking at images of the body, pictures of the body, or x-rays or CTs or something. And we'll want to know whether it's a sagittal plane or frontal plane, coronal, or whatever different way we're looking at it. So we'll talk about the different planes and the sections that the planes cut the body into. Then we'll talk about position and direction, so up and down and left and right and in and out and that sort of thing, the nomenclature that we have for that. And then we'll talk about terms of movement, if we're moving in or out or up or down, what are the specific terms that we use for that. Let's start with anatomy. Anatomy is easy. Anatomy is the pieces. So if you ever have put together a piece of IKEA furniture, the first thing you do is you open it up. First thing I do is I open it up and I take a look and make sure all the pieces are there. I've got all the right screws and the dowels and the bits and pieces. Making sure all the bits are there, understanding what they're shaped like and how they all fit together, that's anatomy. So it's the study of the different parts of the body and their form. Physiology is the study of how those things work together. So how does our body work? So for example, if you look at my hand, if you wanted to describe my hand anatomically, you talk about the different bones that are in the hand, the muscles, the ligaments, the parts of the skin, the types of tissue perhaps that are in there. If you wanted to talk about the physiology, it's about how does my hand do that? How do the muscles and tendons and ligaments connect so that my hand can move? How is it that I, eat my food and drink my drinks and that turns into energy, which somehow gets to the cells in my arm, which somehow makes those muscles move around, which pulls on the tendons and ligaments. So all of that is the physiology. What works is the anatomy. The things, the pieces that are working is the anatomy, and how they work together is the physiology. And of course, this stuff's really important because if we're going to be working with human beings who are ill and we want to help them, the first thing we have to understand are the parts of the body. That's the anatomy. The next thing is how those parts work together. That's the physiology. And then we have to understand what can go wrong with that. What can go wrong with my muscles or my nerves or the blood that comes to my arm so that I can move it. That's the pathophysiology. Patho means sick or wrong or bad. So the pathophysiology, what can go wrong? Once we understand the pathophysiology, then we can understand how that pathophysiology manifests in the body. So if my pathophysiology is cancer or anaphylaxis or asthma or something like that, that presents differently in different people. And so I can go and assess people and find out whether or not they're wheezing or their lab values are off with cancer and they feel weak, or whether they're puffy and itchy and having trouble breathing and hypotensive for anaphylaxis. I can do my physical assessment to hopefully figure out what's going wrong with the patient, and then that leads to my treatment. So it all starts with anatomy and physiology. Those are the basis of understanding how the body works. You understand how it goes wrong. If you understand how it goes wrong, you can understand how that presents. And if you can figure out what's going wrong with the patient, then you can figure out your treatment. So this is sort of the scale of how we treat medical professionals. The first year is usually done doing anatomy and physiology. The middle years are done doing the pathophysiology, and a little bit as we get towards the end, you do more of the assessment and the treatment. So that's how you will be learning your education as you learn about the human body, what goes wrong, and how to fix it. So let's talk about the parts of the body, because as we're doing our assessments, we're assessing different bits, and you're going to want to be able to communicate that with other people. So how do we do that? First of all, big boxes first, we divide the body into three major sections in order to make it easier. So let's figure out what those big three headings are, and then we can break it down a little bit more. So the first part is the axial portion, and axial means the core. So your head, your neck, your torso, your chest, and going down to the bottom of your spine, that's called the axial portion of the skeleton. But the meat that hangs off of that axial part of the skeleton is the axial portion of the body. The limbs and the bones of the pelvis are the appendicular portion. So arms, legs, pelvis, that makes up the appendicular. And then when you're actually looking at the meat, not just the bones, there are cavities inside the flesh of our body. And we break those up into different cavities as well, the anterior and posterior, and we'll talk about what those are. First, let's take a look at the axial portion. We've talked about what that is. So let's start head down. When we're talking about the head, the general medical term for the head is it's the cephalic region. And when we talk about things towards the head, we say it's cephalic in its direction, which we'll get to. So the occiput is the lower back part of the head, this curved bit at the bottom. That would be my occiput. The frontal is the forehead, orbital, the eye cavity. Otic is the ear. So otorrhea, for example, is blood coming out of the ears. Nasal or rhino means the nose. Rhinorrhea, rhinoplasty is an operation on the nose. Oral is the mouth. Buccal is the cheek. Sometimes you'll administer medication buccally, which means you're putting it inside the cheek. And the mentum is the chin. So you might talk about the tracheomental distance. I couldn't think what the trachea is called. Ugh. So the tracheomental distance, for example, is that sort of hyomental distance, is the hyo bone in there. Talking about distances here. So mentum is the chin. Cervical region is the neck. We've got our cervical spine, but everything basically to do with the neck is considered the cervical region. Going down a little bit into the thorax is the chest of the body. So we've got the thorax and the abdomen. When we look at the thorax, we've got a couple different terms. Our axilla is the armpit. The acromion, spelled that wrong, A-C-R-O-M-I-O-N. The acromion is the point of the shoulder. It's the highest part coming off the scapula. Sorry about the spelling mistake. Sternum is the breastbone. It's divided into different bones, which we'll talk about. Pectoralis, you've got pectoralis major and minor are the muscles which make up the chest. Mammary is the breast tissue that sits over top of the pectoralis muscle. And costal is what we talk about when we're talking about the ribs. So if you feel along the bottom part of your ribs, you can feel that up along above the abdomen. That's called the costal region. So that's the terms that we use to refer to the chest. In the belly, we talk about the umbilicus, which is the umbilicus, which is your belly button. And towards the side, we have the flanks. We'll talk a little bit more about the regions and stuff later, but that's good enough for now. When we get into the pelvic region, the inguinal region is the groin, so where the legs meet your body, that fold there is the inguinal fold. The pubis is obviously the pubic area. The genitals, penis or vagina. The anus, bumhole. I don't know what the like common term would be for that. So bumhole is close enough. But that's called the anus, and the muscle that controls it is the anal sphincter. The perineum is the space between the legs, between the genitals, the external genitalia, and the anus. And coxal has to do with the hips. So the whole sort of coxal area of the body down there is the hips. And then we've got the three sections of the back, sort of from the neck down to the bum. So the dorsum region is the upper back. The vertebral region is the backbone of the spine, so the vertebrae that run down the middle is the vertebral region. The scapula are those big wings, the shoulder blades that you can feel at the back, so we use those as landmarks. They're pretty useful. Lumbar is the curve at the lower part of your back. It's also sometimes referred to as the loin when you talk about the loin cuts when you go to a butcher. That's what you're getting. You're getting those big paraspinal muscles that support the animals and support us. And that's what we eat. And then the gluteus or the buttocks are the bum cheeks. Let's take a look at the appendicular portion then. So we've got arms and legs, essentially. That's what makes up the appendicular part of our body. The brachial region is the upper arm. The cubitus here is the back of the elbow. So the other side of that is the antecubitus, or the antecubital fossa. Fossa means a hole or an indentation. And the antecubital fossa, or the ACF, is important because we start intravenous lines in the antecubital fossa, in the vein that goes through there. So we'll often describe an intravenous as being placed in the ACF, or the antecubital fossa. The antebrachial is down here along our forearms. Carpal region is the wrist. Palmar region, obviously, is the palm. The manus is the whole hand. That's where we get terms like manual labor, manual dexterity. Manual is the hands. The pollex is the thumb, and the digits are the fingers. Legs, we've got the femoral, which is the part that surrounds the femur, obviously. So the thigh in the front, the four muscles, vastus lateralis, vastus medialis, vastus intermedius, and one other one, which I can't remember, but the four in the front, and then the hamstring muscles along the back. The patella is the little bone over the front of our knee, and behind the knee, you might think it would be called the antepopliteal fossa, or antepatellar fossa, but we don't. We call it the popliteal space. I don't know why, this isn't logical, but that's what everybody calls it. So the popliteal space is the back of the knee. Crural and sural have to do with the shins, the front of the lower leg, and the back of the lower leg. Tarsal, the ankle. Pedal is the foot. Calcaneus, which actually means stone. That's where calculus comes from, because they moved stones around. So calcaneus is the big heel bone at the back. Plantar is sole, and then hallux is the big toe, and digits are the toes. All just terms you basically have to learn. So those are the head to toe of the body. Let's take a look now at the body cavities, because we've got essentially big sections inside of our body packed full of stuff. So what are those sections? We've got a dorsal cavity, and the dorsum is the back, and we've got a ventral cavity. The ventral cavity is the front. So if we take a look here, we've got dorsal cavity coming along this part, and there's two parts to the dorsal cavity. We've got the cranial cavity and the spinal cavity, and they're potential spaces inside our body, which holds our brain and our spinal cord, and those make up the dorsal cavity. The ventral cavity has the thoracic cavity, and the thoracic cavity actually has several parts to it. So there's two lungs on the either side that sit in pleural cavities, and then between the lungs we have the mediastinal cavity, and within the mediastinal cavity is the pericardial sac, the pericardial cavity. And then below that we have the abdominal cavity, and there's also the pelvic cavity. In reality, these are continuous. There isn't anything structurally that separates these two, so they're usually just referred to as the abdominal pelvic cavity. This is the biggest cavity in the body, and the abdominal pelvic cavity is interesting or important in trauma, because if people are bleeding into their body, there's only so much space for blood to go. So the two big spaces that we worry about people bleeding into are the pleuritic, or the pleural cavities, because number one, you can lose a lot of blood into that space, and number two, the more blood you put in, the less lung you have, because it collapses in the lungs. There's only enough space for a certain amount of stuff. So we worry about people bleeding into their pleural cavities, and we particularly worry about people bleeding into their abdominal pelvic cavity, because you can lose enough blood into your abdominal pelvic cavity to put you into shock and put you into real extremis. So that's one of the things we search for. And there are signs and symptoms of people bleeding into their abdominal cavity, which you'll learn as you go through different parts of your course. Within the ventral cavity, we have the thoracic cavity in the chest, and we have the abdominal pelvic cavity, and they're separated by the strong muscle called the diaphragm. So that's what keeps the sections separate. If somebody's perforated their diaphragm, then that functionally starts to become one cavity inside the body. It's an even bigger cavity, which you can lose even more blood into, and a perforated diaphragm and bleeding into your thoracic abdominal pelvic cavity is very bad news. So don't do that if you can avoid it. And hopefully your patients won't do that. The dorsal and ventral cavities are the big ones. There are also some things that we call open cavities. So if a cavity is like an enclosed space in your body, an open cavity is something that's a cavity, but it's also open to the outside, like your mouth. In fact, your entire digestive tract, as humans, topologically, we're sort of shaped like a donut, where we surround this central hole, which is our digestive tract. So inside our digestive tract, although we commonly refer to that, the stomach is inside of our body, technically the lumen that goes through our digestive tract is a part of the outside of our body, mathematically, topographically speaking. The respiratory tract is one of those spaces as well, because we can breathe in, it goes into the lungs, and it comes out. And the urinary tract is another one. And why do we care about the open cavities? It's because there's an opening from the outside where bacteria can get in into warm, moist environments, often with a lot of nutrition in there that they can get to, the bacteria can get to, and that's where we get infections. So when people get infections, they usually get them in their sinuses or their ears, or within the digestive tract, or within the respiratory tract, or within the urinary tract. So if somebody comes in with unexplained fever, we usually start thinking about, well, which open cavity is the one that's infected? So it's important to know which the open cavities are. Okay, surface anatomy. So if you're looking at the outside of somebody's body and you want to describe where, take a pen and put a dot on somebody, and then the other person who can't see them says, well, where's the dot? You have to describe it. We've got a lot of medical terms for how to do that as well. So let's take a look at that. The surface anatomy is what you can actually see and what you can feel when you're examining a patient. The head and neck, we talk about the frontal is the forehead, temporal is the side, parietal is the back top, occipital is the back bottom, cervical we've talked about. The maxilla, actually the maxillae, there's two maxilla bones which connect, and there's two mandible bones which connect. So we've got those bones as well. Down the front of our throats, we've got our larynx, which is sort of the Adam's apple thing. And below the larynx is, if you feel this, it's a lot easier to feel on a guy who's got a big trachea. But you can feel down, there's the big prominence of the trachea. And if you come down right around here, there's a little dip between the lowest part of that and then going down to the trachea. And then you can feel the tracheal rings as you travel down. So that very top space between the larynx and the beginning of the trachea, there's a little divot, and there's a cartilage that connects the top to the bottom, and that's called the cricothyroid cartilage, or the cricoid cartilage. And the reason that's important is because if you're ever going to do a surgical airway, which you should never do unless you've been properly trained. I've spoken with enough people who said, oh, I saw MASH and Hawkeye did a cricothyrotomy, surgical cricothyrotomy on Father Mulcahy and with a pen, which wouldn't work because the lumen's too small. Anyway, people seem to have an idea that this is a simple thing to do and it's not really dangerous. In an emergency, I just cut into their neck. Don't do it unless you've been trained, because it's highly vascular and you could do a lot wrong. Anyway, I just don't want to encourage anybody to do that. But that's the cricothyroid cartilage, and it's anatomically important because clinically we surgically enter into the trachea through there. And then when you take a look at the back of someone's neck, you'll notice that there's a prominent sort of vertebrae at the bottom whenever somebody bends over. And that's the seventh cervical vertebrae, or C7. And that's an important landmark for knowing, whether you're above, you're in the cervical, or whether you're going down further into the rest of the spine. The other thing is that our necks are very vulnerable. There's a lot of important stuff inside of our necks, and we want to be able to identify what's going on in the neck and where we are. So in terms of whether you're superficial or deep to the neck, we've got this thing here, this stuff when you go like this. I can do it really well, look like a frog. This is called the platysma. And the platysma is a fascial layer. It's a layer of connective tissue that covers over the outside of the neck. And if something cuts your neck, surgeons will take a look at that, or physicians will take a look at that, and they'll examine whether or not it's gone through the platysma. And if it's gone through the platysma, then they're going to take you into surgery and probably surgically explore just how deep that wound is. But if it's superficial to the platysma, then it's just the skin, and they're not as worried about that sort of a penetrative injury. So in terms of up and down, we divide the neck into 3 zones. So you've got the angle of your mandible here, the angle of your jaw, just by the TMJ there here. You can feel that angle. If you go above, so that angle would kind of come across at the level of our mouth or lower lip. If you're above that, so up here in this part of the neck, that's considered zone 3. From the angle of the mandible down to that cricoid cartilage, which we were talking about, that's considered zone 2 of the neck, and below the cricoid cartilage, we're down into zone 1. So that's if you want to determine how high or low you are. Something going in up here, that's in zone 3. Something going in down here, that's in zone 1. So that's useful for describing it to somebody or charting it. The other thing is, now that we've figured out how to go up and down, we want to figure out how far around we are. And if you take a look at it, starting at the menton here, starting at the chin, you go out to the angle of the mandible, that's kind of the top of a triangle which comes down like that. So you got these nice strong muscles here, sternocleidomastoids, comes down, and this is a triangle. So we call that the anterior triangle of the neck. And then if you look from the side, this is the line of the anterior triangle. If you go to the back of the neck and up, that's the right lateral triangle, and this is the left lateral triangle. So by saying something like, boom, I got stabbed here, I got a platysmal penetration injury that's in zone 1 of the neck in the middle of the right triangle. That's how you would describe sort of that position. So it's very useful for, trying to describe on the phone to a surgeon from the emerge, or as a paramedic trying to describe over the phone to a base hospital physician of, this is the injury that we've got. Should we take him to a trauma center? What do you think? Blah, blah, blah. So that's how we describe the neck. Then we get down to the chest. So when we feel along the chest, you can feel there are these bones along here, commonly called the collarbones, which the medical term for them is the clavicles. And then as you feel in towards, so from the outside here, we got the acromion, and then we go along the clavicles in, and then you'll feel there's a little sort of a U-shaped notch. And that here, if you push in the martial arts, to get people to move away from you, you push in and down on that, and really it's pretty uncomfortable. So that's called the suprasternal notch. It's a useful sort of landmark to have. And then as you go down, you can feel that in the middle of your chest, there are these bones. The top bone here, this little shape here, this one is the manubrium. And then the body down here is called the gladiolus. And then right down on the, it's not a great mouse, right down on the bottom here is the xiphoid process. And a lot of people know about the xiphoid process because they took a first aid course and they learned how to do CPR. And when you learn to do CPR, they tell you don't do it right at the bottom of the breastbone. Do it in the middle of the breastbone, on the gladiolus, because if you go down and you push on the xiphoid process, you can break that off. And those sharp bits can cause internal lacerations. And sometimes they'll tell you, it'll go and it'll cut your liver in half, or, these dramatic sort of statements. Probably not. It's just a little bit of bone and it's embedded in connective tissue. But it does cut things. And in the worst case scenario, you could nick a lung or your liver or spleen, something. It's just not a good idea to go breaking people's bones. So when we're doing CPR, we want to be right up at the top in the middle of the gladiolus so that we're well away from the xiphoid process. If you go out to your clavicles as well, you'll feel as you come down that there's a bit of a divot, and then it kind of comes out again, and then there's another little divot, and then it kind of comes out again, and your chest is kind of corrugated, and that corrugation is the ribs. So you're feeling the ribs underneath your chest. Your first rib that comes off of the spine actually comes out underneath the clavicle. And if you're feeling around here, you can't feel that rib. So what you feel instead is the clavicle, and then you feel the first space, this thing here, this space, if this is a rib and this is a rib, we call those intercostal spaces. Remember we said costal means rib? So the space between the ribs isn't called an interrib space, it's called an intercostal space. And the space between the first rib, which we can't feel, and the second rib, which we can feel, is called the first intercostal space. So we go from the clavicle down to the first intercostal space. Try this at home, kids. And that's the divot that we feel towards either side of our chest. In the middle, obviously, we don't have ribs, so you won't feel it. So that's the first intercostal space, and then the first bump that you feel is the second rib, and then down to the second intercostal space, third rib, third intercostal space. And if you're having trouble feeling them, instead of like touching with a point, lay your fingers a little bit flat, the pads of your fingers, lay them flat, and move up and down, and then you'll be able to feel them a little bit better. That sort of landmarking is really important. So for example, if you have a collapsed lung, a tension pneumothorax, one of the things that we do for that is we stick a needle into your chest. And in terms of determining how far up and down we go, we know that we go into the second intercostal space. So, you don't want to go too high or too low. That's how we determine it. If you keep on going down the ribs, down, 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 eventually you'll get to this border at the bottom of your ribs, which kind of comes down over the top of your abdomen. And that's called the rib margin, or in medical terms, we call it the costal margin. And then we get down into the abdomen, and we'll talk about the quadrants of the abdomen in the next slide. Here. So if you draw a line through your belly button, up through the middle of your body, and then draw another line around through the sides, as you can see on the slide here, we've divided our abdominal cavity, or abdominal region of our body, into 4 areas, 4 quadrants. Left upper quadrant, right upper quadrant, right lower quadrant, left lower quadrant, which is useful in how we use them. There's another way that people divide it into 9 sections, but I forget what those are. We hardly ever use them anyways. If you are right in between the middle of the left and right upper quadrants, then we call that the epigastrum. So we've got some terms. The epigastric region is above, and you can see here, this line coming down there, that's your costal margin. So between the costal margins up at the top is your epigastric region, and then the periumbilical or periumbilical region, and then lower down at the bottom of the abdomen. I keep wanting to say abdominal cavity, but it's not the cavity because we're external. So at the bottom of the abdomen is the pelvic region of the abdomen.